I'm so sorry for these technical issues, but finally, uh, thank you, Dr. Saul and Dr. Puri, for providing me an opportunity to present in this grand round. And today I'm going to discuss what Lennox-Gastaut syndrome, some treatment evidence-based treatment, and some new treatment updates which are in pipeline. So just objective of this talk would be like some history, definition, and diagnostic criteria of LGS, etiology, evaluation, and then mainly treatment options I want to discuss. And then treatment strategies of LGS beyond childhood, because kids often transition into like adolescent and adulthood, and they need the good transition of care to the adult neurologist or adult neurologist. So this epilepsy syndrome usually begins in childhood, usually age 1 to 8 years, which worsens during latency and persists frequently into adulthood. Is usually refractory to all many anti-seizure medications and usually result in cognitive decline and behavioral problems in affected individuals. Going back to history, the definition and classification has evolved over the years. It started in describing this spectrum of patient from 60s, 50s, and 60s. Initial Gibbs and co-workers described a slow spike wave pattern, which was termed petit mal variant. Later, Lennox and Davis described the clinical picture with this particular EEG pattern. Dr. Lennox defined a clinical syndrome with a triad with specific EEG pattern of slow spike wave, impaired cognition, and multiple seizure types, including myoclonic atypical absence and drop attacks. Later, Dr. Dravey wrote a thesis describing 50 patients of LGS under mentorship of Dr. Henry Gastaut. And then Dr. Gastaut expanded this to include 100% patients, and then first time published in 1966. With this large cohort of LGS with all the electroencephalographic features and clinical description. Then later in 1968, in the European meeting, it was Dr. Lennox's daughter who proposed to use the term Lennox-Gastaut to recognize the contribution of both physicians to this syndrome. Later in 1989, ILAE tried to define this syndrome, and they included the most common seizure type, atonic atypical absence, followed by myoclonic tonic-atonic drop seizures, generalized tonic-clonic seizures, and focal seizures. And these seizures were often intractable. Cognitive impairment is universal, and the typical EEG feature shows a slow, less than 2.5 hertz spike in wave pattern. The onset of this syndrome usually is 2 years to 8 years, and it accounts for 2 to 5% of all childhood epilepsy. Since the diagnostic, clinical, and EEG features may not be present at the onset, the diagnosis of LGS may emerge only over the years on follow-up. Going to its etiology, it's very broad spectrum etiology, mostly like all those infantile epileptic encephalopathies, they evolve over the years into this particular syndrome. So etiology include like symptomatic or cryptogenic or genetic epilepsies, symptomatic including like any kind of structural damage to the brain as like developmental cerebral malformation, HIE, TBI, and tuberous sclerosis, any like symptomatic infantile spasm for any reason, intracranial tumors, And in cryptogenic, usually 25 to 30% of cases where we find non-lesional, normal prior development, no identifiable cause, but presumed genetic, as nowadays, as we explore more epilepsy panel, and we find more genetic epilepsies which were categorized as cryptogenic before. The typical seizure patterns include tonic seizures, atypical absence seizure, drop attacks, and other type of seizure, including generalized tonic-clonic seizure, myoclonic seizure, and focal seizures. So the tonic seizure is the most common seizure type in this syndrome, and this seizure must present for the diagnosis. They are diurnal, usually common in non-REM sleep, and they are categorized based on the involvement of the body, axial tonic, axorhizomelic tonic, or global tonic. Axial tonic means slight head flexion or trunk flexion, sometimes contraction of the masticatory muscles, resulting in some vocalization. Axorhizomelic is usually involvement of proximal upper extremities with some elevation of shoulder and abduction of arms. Global tonic seizures usually involved contraction of distal part of the extremities, and this often leads to the fall because of imbalance, and sometimes it mimics the infantile spasm if present in earlier age. This usually is very brief, lasting for a few seconds. It could be very subtle, just like tonic eyelid opening, and can be associated with the autonomic changes like pupillary dilatation, urinary incontinence, some tachycardia, flushing, and usually sleep activated. So this was a quick video of one of the tonic seizures. So here you can see the slight tonic flexion of the neck, as well as the upper extremities, axorhizomelic kind of tonic seizure with the mild abduction of the arm, raising of shoulders, and the head flexion. Then another seizure type is atypical absence seizure. It also has the same frequency as tonic seizure with this particular type of syndrome, and usually the difference between typical absence seizure and this atypical is usually this is very gradual onset and usually takes longer time to return to baseline compared to the typical childhood absence seizure. May continue to do pre-ictal activities during the seizure. They usually not activated by photic stimulation or hyperventilation, and they may have some motor activities during this seizure, some tonic or atonic components. Then third seizure type is drop attacks or atonic or astatic seizure. They usually can be associated with, along with the tonic, atonic, or myoclonic atonic seizure, and usually they are 10 to 50% times they are associated with this type of syndrome. Frequently results in facial injury and falls because of that, so they require head and facial protective helmets. And other seizure types like generalized tonic-clonic seizure, myoclonic, and focal seizures can also be present, but these are not need to be present for the diagnosis of LGS. Often 70% of the patients with LGS have two or more seizure types. 50 to 75% have episodic non-convulsive status epilepticus, which have diffuse slow spike and wave or diffuse high voltage delta activities with multifocal waves or spikes. The electroencephalographic features is diagnostic is slow spike and wave complex, usually less than 2.5 hertz, lasting for seconds to minutes. Usually bifrontal, frontal predominant with maximum voltage over there. There is no activation with photic or hyperventilation. Usually the background is slow PD are expected for the age, and these are sleep activated. So here is one example of this spike and slow wave. Usually is like 1.5 hertz spike and slow wave. And then the ictal electrographic features with the tonic seizure, usually they begin with the low amplitude first rhythm and may be preceded by the burst of generalized slow wave and stop and slow wave, followed by relative attenuation for a couple of seconds of the ongoing EEG activity. And atypical absence seizure usually have long runs of slow spike and wave activities, maybe very similar to interictal pattern, but more sustained. Now comes the management part. Basically, I'm going to discuss the anti-seizure medications and some non-pharmacological options, and we'll see the evidence to support it. So this is the basic treatment sequence. We always start with first anti-seizure medication as monotherapy, then add second. We can try polytherapy, but that time we need to reevaluate and can consider other treatment options, including ketogenic diet, VNS, or other epilepsy surgery. And we have these treatment options, including anti-seizure medication. There are 6 or 7 medications which are FDA approved for the LGS, including felbamate, topiramate, lamictal, rufinamide, clobazam, Epidiolex, and valproate. Anecdotal open-label retrospective studies show some effect of valproate, clonazepam, vigabatrin, zonisamide, levetiracetam. A ketogenic diet is a good option to decrease the overall seizure frequency or drop seizure, as well as VNS and complete corpusculostomy. And then apart from these, like the other protective measures like helmet and other seizure safety measures. So these are FDA approved medication, and nasal diazepam, midazolam, and rectal diazepam for the seizure cluster. So valproate is the oldest medication in this group of medication, and this was described in 1982. It was kind of retrospective chart review of like almost 650 patients that shows like 18% seizure reduction in patients of LGS. And since then, since this is very good medication for generalized seizure, it was always been used as monotherapy or in the beginning. Then comes felbamate. This was a randomized controlled trial in 90s, and that showed the reduction in drop attacks almost like 34% compared to placebo. and that was significant statistically. And there was 19% total seizure reduction compared to placebo. Then later, lamotrigine had like randomized clinical trial, which showed reduction in drop attacks almost the similar as the felvamet, like around 34% compared to placebo, while total seizure reduction was 32%. Then later in 1999, the topiramate was tried in a RCT, which showed total seizure reduction around 20% compared to the placebo 8.8%, which was not really significant statistically, but drop attacks were reduced by 15% approximately compared to placebo. Then later in 2008, the rufinamide showed a little promising effect on reducing drop attacks to 42.5% median seizure reduction in seizure frequency compared to placebo, which was significant, as well as the total seizure reduction was around 32%. Then the latest on this drug list is the OMPI or clobazam, which had tried in 3 different doses, low, medium, and high doses. High dose was 1 milligram per kg per day. It was very good reduction in drop seizure up to like 68.3% compared to other doses as well as the placebo. And total seizure reduction was similarly 65.3%. And then cannabinoids or the Epidiolex was tried in 2 different doses, 10 milligram and 20 milligram compared to placebo later in 2018, which showed a total reduction in drop seizures around 42% as compared to total seizure reduction 38% with the higher dose of 20 milligram. And non-drop seizures were significantly reduced to 61% with low dose cannabinoids. And so especially in the drop seizure, more than 50% reduction was seen in like almost 40% of the patients, while more than 75% reduction in drop seizures were seen in about 25% of the patients. So this is the overall all the medications randomized clinical trial which was tried in LGS. So you can see compared to placebo, the OMPI was very significantly involved in the seizure reduction. And there was another trial which was done with CBD as well as the OMPI combination, and it showed the similar seizure reduction around like 60 to 70%. So these are just the comparison of some recommendations for treatment of intractable pediatric epilepsy. So for the LGS, Japan, ILE signed the NICE guideline, European guideline, and the FDA approved drugs for LGS. We have FDA approved felvamet, topiramate, lamictal, rufinamide, clobazam, and they also approved now the Epidiolex. And this is similar, the different expert opinion, the effective medications. So still like as monotherapy, the valproate, lamictal is a preferred choice to start with, and then go on the second tier medications. The usual side effects of these anti-seizure medications, the felvamet as worrisome side effect is aplastic anemia, liver failure, and common some decreased appetite, GI-related, some tiredness and insomnia. Similarly, Topomax has decreased appetite, tiredness, poor concentration, but cognitive delay and decreased sweating is a little worrisome side effects to be aware of. Similarly, Lamictal has serious RAS. This benzyl has very rare RAS, but usually often with associated with vomiting and tiredness. Similarly, Ompi has aggression, ataxia, tiredness, drowsiness, and some behavioral changes. Epidiolex have somnolence, decreased appetite, diarrhea, but the abnormal liver function test usually, like when we use with other hepatotoxic medication like Ompi or Valproate, we should be careful about this complication. Then these are some medications which usually exacerbate the seizure types in this syndrome, so better to be avoided these medications, which includes like sodium channel blocker, mainly carbamazepine, oxcarbazepine, which worsens myoclonic atonic seizures, similarly phenytoin, phenobarbital, and some tiagabine, vigabatrin, gabapentin, and lamictal sometimes worsens the myoclonic seizures. Then comes newer medications which there are in pipeline or like going into clinical trials currently in phase 3 are fenfluramine. Fenfluramine medication was used before as an anti-obesity drug, and it is a kind of serotonergic drug which has, apart from the serotonin, it also acts on the sigma-1 receptor. Exact mechanism is not known. It has been approved. This medication has been approved for the Dravet already, and this is the phase 3 clinical trial going on with the low dose of 1 to 2.7 milligram per kg per day in LGS. So preliminary findings that showed about more than 50% reduction in seizure frequency in 25% of the cases compared to placebo, which showed 10.3%. But still, full study results yet to come. So, other newer drugs have been used as Fycompa or perampanel. There was just a case report of 13 patients in 2017, which showed more than 50% seizure reduction in almost 70% cases, with more than 75% seizure reduction in 23% cases, but sample size is too small to conclude anything. This medication is also in phase 3 clinical trial, which was just completed this July 2021, and we're still waiting for their final reports. Then another medication is soticlestat. It is one of the inhibitor of enzyme in steroid or cholesterol 24 hydroxylase, which was thought to be predominantly expressed in brain and probably involved in the excitatory pathway. Exact mechanism is not known, but it is thought to be associated with some modulation of excitatory pathway, and currently it's in phase 2 clinical trial, which started in 2018. So, and few medications are in phase 1 clinical trial at present. Carisbamet is one of the medication from the Carbamet group, which also include the Felbamet and Cenobamate. And this medication is in phase 1 trial. Then another medication is ganaxolone, which is a GABA A receptor modulator, usually activates the synaptic and extrasynaptic GABA A receptor at site distinct from the benzodiazepine and barbiturate GABA sites. And this is currently getting studied in specific genetic epilepsy, CDKL5 deficiency, PCDH19 related epilepsy, but this also is planned for the going into the phase 1 and phase 2 trial for the LGS. Then other non-pharmacological interventions include ketogenic diet, which according to Cochrane database review of article, they showed significant seizure reduction about more than 50% in 35 to 56% of cases compared to 0 to 18% in control group. And similarly, in 2020, recently, the systemic review in infants is less than 2 years, approximately showed the similar seizure reduction is about 59% of the infants in KD group compared to 33% infants, among which 33% infants achieved seizure freedom. Then comes surgical option, including vagus nerve stimulator. And this is a review of article like systemic review until 2009, which shows mixed response ranging from 25% to 78 to 80%. But in larger cohort in 2001 by Prostitel, it showed around 43% responder rate, with median seizure frequency reduction is around 33% to 60%. In 2013, after reviewing all those literature, the AAN has updated the guideline for the VNS treatment for the epilepsy. And in Lennox-Gastaut syndrome, they found with the 113 number of cases, about more than 50% seizure reduction in 55% of the cases, which were significant. Then later this year in 2021, they also reviewed, this is also systemic review from 2002 to 2011. They included all these studies with showing still 54% seizure reduction, especially with the responder rate. So it's similar efficacy around 50 to 55% seizure reduction with the VNS. And corpus callosotomy have been mostly shown to be effective to decrease the drop seizures, but it also have been seen to decrease the total seizure reduction, including other seizures. So this was one small study which was published in 2020. They have included 10 patients with the LGS. The age range was ranging from 11 to 52 years. They did the MRI-guided stereotactic laser anterior corpus callosotomy, and they showed about more than 80% seizure reduction in drop seizures specifically, was almost 80% of the patient, and among which almost 50% become completely seizure-free. And in terms of total seizure reduction, about 60% of the patients showed more than 80% of the seizure reduction, and among which two patients, about 20%, had been achieved total seizure freedom. So this general treatment approach, when we start first line with valproate and clobazam, lamictal, Second line, we can choose from the FDA-approved medication, including rufinamide, CBD, Epidiolex, topiramate. Other medications people do try: Keppra, jonissamide, perampanel, brivaracetam, and definitely at this stage, we should consider the non-pharmacotherapy, including ketogenic diet, evaluation for VNS or corpus callosotomy. And then the last line, because of the worrisome side effects, the felvamate is good drug that can be tried at last. Then these are the medications which are in pipeline. Then after taking care of these patients during the earlier childhood and adolescent, when we transition to the adult care, often there are expert opinion regarding the guideline when you get these type of patients who have either diagnosis of Lennox-Gastaut syndrome, but even if there is no diagnosis labeled as Lennox-Gastaut syndrome, it is good idea to evaluate if there is any past medical history of multiple seizure types in childhood, early age of onset and developmental delay, history of cognitive impairment, with finding anything related to either hemiparesis, quadriparesis, cognitive impairment, any neurocutaneous syndrome, stigmata on examination. Then you can either ask to the pediatrician about the medical record. If they already have a diagnosis of LGS, then the LGS can be treated as LGS. If there is no such prior records showing any diagnosis, then definitely you should get a EEG and see if that qualifies for the diagnosis of LGS, including slow spike wave activity, diffuse fast rhythm. And if not, then if it is undetermined, we can obtain long-term monitoring, including sleep, which can clarify this diagnosis. And if the EEG at this time remains normal and based on these different type of seizure and other comorbidity, could be possibly LGS. It is, and if it is this different type of seizure with other comorbidity is still with normal EEG, we should treat it like LGS and try the medications which are approved for the treating LGS. So that includes the similar thing, the Tier 1 anti-seizure medications, including valproate, clomazone, and lamictal, Benzyl, topiramate, cannabidiol, and then go to the Tier 2 and Tier 3 include felvamate, Vimpat, brivaracetam, Xcopri, and other medications. And these are few medications, the sodium channel blocker to be avoided in this situation. And then the other non-pharmacological treatments should be tried. They need the social worker and social support, other accommodation in school for transportation, extra help, and then equipments and protective gear like helmet and other stuff to prevent injury from the drop attacks. And so finally, as a summary, LGS is a very devastating epileptic encephalopathy of childhood, usually persists in adolescent and adulthood. This is a refractory epilepsy and polypharmacy is often required, but the careful selection of effective anti-seizure medication usually helps, and we should be aware of to avoid some anti-seizure medications, especially the sodium channel blockers, which can exacerbate these seizures. And early integration of non-pharmacological options, including diet and surgery, provides better quality of life. And they usually need multidisciplinary approach to take care of these patients with the LGS. With this, conclude the presentation. And if you have any questions.
Dr. Sao, I have a question. Does fenfluramine help seizure control by inducing any weight loss, or is there a completely separate mechanism, or do we know that any weight loss may help with
Fenfluramine?
Yeah.
I mean, fenfluramine has been shown to be effective on some sigma-1 receptor. And in Dravet clinical trial, it has been proposed that it works similar to captora mechanism. They act on the synaptic vesicle to release the neurotransmitter. So I don't know if indirectly associated with like seizure reduction due to obesity and deficit.
Thank you.
Any more questions?
I have a question.
Sure.
You typically take care of these kids when they transition to the adult side.
Can you repeat the question?
Sorry, I think there's an echo.
Yeah.
I was just wondering who takes care of these kids on the adult side? Or do we continue to take care of them?
Hello. Still echoing. Sorry. Hello. Hello.
Dr. Sao, could you answer the question that was posed, or?
Yeah, I didn't listen to. Can you repeat the question, please?
I think the question was who takes care of these children once they become adults?
So that's the important thing. Like, usually we take care of until 18 or 21, and then there should be careful transition to the adult epileptologist or neurologist, with all those documentation of previously tried medication, what's the medication on, and for the plan or something, if there is anything surgical options or is surgical intervention have been done or not. So it's like age based, but there should be careful two-way communication between the pediatric epileptologist and the transitioning adult neurologist or adult epileptologist.
All right. Thank you very much for the presentation. I think it was very helpful for all of us to hear about upcoming drugs and treatment options. Thank you.
Thank you so much.
Have a great day.
Bye.